morning, everybody. I welcome everybody around the globe. And first of all, I would like to wish everybody a happy new year with a lot of positive adventures in 2022. Dr. Rafa Alonso is in Spain and is enjoying probably the warm weather. It's a little bit warmer than it is in Ottawa. So it is my great pleasure to introduce Dr. Andrew Crean, who is a professor of medicine within the division of cardiology and acts as the co-director of the cardiac MRI service at the University of Ottawa Heart Institute and is director of the adult congenital heart disease in Ottawa. He has a very interesting journey as a trainee and staff physician. He received his medical training at the University of Southampton in UK. He then moved on to his specialty training in radiology in Edinburgh and focused his training in cardiac imaging in Cambridge. He then spent an additional 5 years of a residency in cardiology in Leeds, UK. After accreditation as a specialist in radiology and cardiology, Dr. Crean joined the staff of Toronto General Hospital in 2008 with cross appointment to the Division of Cardiology and Department of Medical Imaging. He then continued his journey at the University of Cincinnati Medical Center in the US and at the Ottawa Heart Institute. During his time in Toronto, he established the first dedicated service for adults with congenital coronary anomalies in Canada. Andrew, we are looking forward to your presentation, Coronary Anomalies. Which ones to worry about?
Owen, thank you very much for that kind introduction. Good morning, everybody, from a cold and snowy Ottawa. I hope it's nicer where you are. So I was very pleased when Rafa asked me to talk on this topic, which I think is interesting and difficult. You know, many of us go into adult congenital heart disease to get away from bog standard coronary work, but it seems that I ended up with coronaries after all in one way or another. So I'm going to spend the next 30 or 40 minutes talking about some common and less common coronary arteries, which ones we should worry about, and which ones I think we probably don't need to lose too much sleep over. And then at the end, I'm sure we're going to have some lively discussion. So I emphasize that everything that I show you is very much a personal view, and I think it'll be interesting to see what you're doing at your centers for some of these lesions. So I thought we would start with a brief background and then move straight on to discussing the different types of anomaly. And you'll see that I'll split these up by how much they should concern us and as cardiologists or as cardiac surgeons. And then we'll finish up by talking briefly about an approach to testing in this kind of patient. So the true frequency of anomalies, it varies a bit depending on what study that you look at. One of the often quoted studies is the Texas Heart Study, where 2,000 sequential angiograms were looked at and detected an anomaly rate as high as 5.6%. I think this is a little bit on the high side. It's probably artificially inflated because they included things like a coronary artery which arises at the level of the sinotubular junction rather than from the cusp. And although strictly this is an anomaly of origin, I think many people would consider this to be a normal variant. And then in other large sequential studies, particularly one from the Cleveland Clinic, where they took a sort of more stringent definition to what was an anomaly, there was an anomaly rate of about 1.3%. And that was subsequently very similar to that was seen in a Chinese CT study of almost 2,000 studies. So probably around 1% mark for anomaly rate certainly based on imaging. Of course, individual lesions can be much less common than that. So, you know, this is one way of thinking about classifying coronary anomalies, and it's the sort of break down the sort of list we might have regurgitated in exams in years gone by. But, you know, I feel that this kind of anatomic classification really doesn't tell us anything very much about the physiologic significance of each lesion. And I think our task is to try and sort out these anomalies into one of 3 groups: those which cause almost obligatory ischemia, those which really don't cause ischemia except in very rare circumstances, And then, of course, the most difficult group of all, those which can lead to ischemia, but equally don't always do so. So let's start by just mentioning a rare but critical anomaly. This is the transeptal. This is the left main arising from the right coronary cusp. This is a very rare anomaly, which is associated with sudden death. This is the only case I have seen, and it's not even one of my own cases. It's from a colleague, Dr. Deshpande in Leicester. This is associated with a high risk of sudden cardiac death. And I think one of the reasons that we don't see it very much at all as adult congenital cardiologists is that either the patients don't survive or they've been picked up and fixed in pediatric life. So I mention it because it's probably the most high risk of all the lesions that I'm going to talk about today, but equally it's the lesion that I think you're probably least likely to see in a career. And in 15 years of adult congenital heart disease, I've actually not encountered one of these unrepaired in an adult. The risk, of course, is sudden cardiac death, and here's an example from the literature. Just turn on my pointer for a second. You can see that there is an anomalous left main system which is running between the aorta and the RV, and actually is running in the wall of the aorta, and we'll talk about that more in a minute, what it means to have an intramural segment. And post-repair, the artery's been reimplanted, and there's no longer any intramural component or any passage between the great vessels. As you know, repair in these cases usually involves an unroofing procedure where the surgeon goes inside, snips off the roof of the vessel and opens it up and creates a nice wide ostium for blood to flow. So if you see one of these in a career, I think you're lucky. I'm still on the lookout for an unrepaired one in an adult. The next group of anomalies, however, are rare but important, and I think all adult congenital cardiologists will see this. And this is the anomalous coronary artery from the pulmonary artery. In most cases, the left pulmonary artery, so an ALCAPA. And this is seen at about 1 in 300,000 births, and it was first reported in 1939 by Bland, White and Garland, and that's the alternative name, the Bland-White-Garland syndrome. This is an important anomaly because it can be associated, or is not infrequently associated, with sudden death. It's often regarded as an abnormality of origin because the mouth of the left coronary artery attaches to the main pulmonary artery. In fact, it seems to me in many ways it's more an abnormality of termination, at least in terms of flow physiology. So what do I mean? Well, here you see an angiogram with an injection into a normally arising right coronary artery. And if we go through frame by frame, you see faint collaterals appearing, and then as we go into later frames, you see reconstitution of the LAD through flow through these collaterals, which are both transeptal collaterals and apical collaterals, and eventually we see full reconstitution of the LAD as it disgorges blood back into the pulmonary artery. And I want to emphasize these collaterals because they're there in every single case of ALCAPA and ARCAPA. And this transeptal collateral network can sometimes be the first clue about what you're dealing with. So the diagnosis can be established very quickly and easily by CT. Here's an example here. You see the left coronary arising from the main pulmonary artery just above the pulmonary valve. But having established the diagnosis, I think a lot of centers move on to MRI because we want to know about volume, function, ischemia, and potential scarring in the heart as well. And I would say there's basically obligatory ischemia in these cases. This is a series of stress MR images. This is the same patient with rest MR images. And you can see that there's a dense subendocardial perfusion defect, this dark defect, which is dominant in the left coronary system, maybe even with a little bit of ischemia in the right coronary system as well, but almost invariably ischemia in the left side. Now, I just want to come back to these collateral vessels again that create the fistulas network. You can see them even on MRI. You can see these little bright lines here. These are transeptal collaterals. In another view, they may look like little dots. These can be confusing sometimes to MRI readers because when you look at the late gadolinium images, you often see little bits of white in the septum, and sometimes it wrongly gets called scar, when in fact what it is just contrast within these transeptal collaterals. Why am I banging on about these? Well, because they are the first hint of a collateral network on echo. So these things are readily appreciated on echo in ALCAPA and ARCAPA. In fact, in many patients with extensive collateral transeptal flow. And what you see is typically twinkling blue and red lights on color Doppler in the septum, sometimes called Christmas tree heart or Christmas tree septum. So when you see this, you always want to be looking for flow back into the main pulmonary artery. And this is a good hint that you may be dealing with an ALCAPA. So it's unusual to see an ALCAPA that hasn't been repaired who does not have ischemia. As we've said, I mean, this is essentially a Steele syndrome. You've got blood flowing from high aortic diastolic pressure at the right coronary end down to low diastolic pulmonary artery pressure at the left coronary end. And the degree of Steele can be so significant that perfusion differences can be even seen at rest. So here are 3 patients, all with unrepaired ALCAPA, all with dense perfusion defects in a left coronary territory, and these are all with stress. This, however, is a patient of mine who runs or was running marathons prior to the diagnosis, and this is just a normal resting CT that I've color coded, but it's a standard CT. There's no stress involved, and you can see that even in this case, there's differential perfusion between right and left coronary territories. So ischemia is the rule in ALCAPA, and it's one of the indications for repair. Now, the majority of ALCAPA series that have been published are pediatric, because this is usually when it's encountered. We were interested in the natural history of ALCAPA when it presents for the first time in adults, which is less common. So last year, Emily Laflamme, who was one of our fellows in Toronto, reviewed all of the cases from Toronto over a 25-year period, and she put together a nice paper in Michael Gatsoulis's new Congenital Heart Disease Journal, which was published last year. This is the reference if you're interested. So who were these patients? Well, we had 18 patients in the series. There were 16 with ALCAPA and 2 with ARCAPA. There was a range of ages at presentation from 18 to 56. Symptoms were generally chest pain and breathlessness. Some patients were found incidentally because of imaging for some other reason, but 2 patients presented with aborted sudden cardiac death. So generally, as a whole, apart from the 2 who presented with sudden death, this population were quite well. In fact, they were NYHA class 1 to 2, and several of them had uncomplicated pregnancies. There was not a lot of associated congenital heart disease. There was a bicuspid aortic valve, and 2 patients had AB canal defects, 1 with PAPVR, but otherwise ALCAPA was an isolated lesion. And they went on and had a range of surgeries, although reimplantation was the commonest. They did well post-operatively. EF was mostly in the normal range, and most patients were NYHA class 1. Importantly, there were no further episodes of sudden cardiac death. There was 1 patient who died from heart failure, unfortunately, but no sudden deaths. And we were interested partly, amongst other things, in reviewing the ischemic burden in these patients before and after surgery. Now, remember, this was a retrospective study. We had pre and post data in only 7 patients, and it's a mixture of SPECT and MRI studies, so it's a bit messy. But you can see, despite this, that in almost every case, the perfusion defects pre compared to post, the perfusion defects were extensive and severe prior to surgery, and then post-surgery, they either disappeared or they became much less extensive, suggesting that the re-establishment of antegrade flow is beneficial, at least in terms of perfusion, physiology, and perhaps explains the low sudden cardiac death risk in the literature after surgery has taken place. So turning briefly to ARCAPA, the sister lesion, and anomalous right coronary artery from the pulmonary artery, this is much less common. There was this nice systematic review of all published cases of ARCAPA in the literature that came out a couple of years ago. There were about 223 cases that they found. And it's relevant to us as adult cardiologists that 46% of these patients actually presented after the age of 16. So you're likely to see this in practice. I've seen a couple so far in my career. And in fact, there was a bimodal distribution of presentation. So either they occurred in infancy or between the ages of 40 to 60. And of relevance to us in this series, 11% of adults presented with heart failure symptoms. And in just under 3%, the first warning was sudden cardiac death. This is an example of ARCAPA. This is a 50-year-old patient of mine who presented at the age of 50 and was completely asymptomatic, found by complete chance to have ARCAPA. And you can see that the right coronary artery, which is very dilated here, connects to the main pulmonary artery. You can also see the left coronary artery is very dilated, and although we don't see transeptal collaterals on the CT volume rendered image, there were lots of collateral connections as well. Again, the size of these vessels is due to the high volume flow following a diastolic pressure gradient from aorta to PA. Now, like all of these patients, I ischemia test them. This individual was interesting. He had negative ischemia testing with both SPECT, shown here, and also negative stress MRI. However, I have had other patients with ARCAPA with both symptoms and perfusion defects. And there are plenty of case reports of ARCAPA patients dropping dead out of the blue. I think most people believe that both ALCAPA and ARCAPA should be repaired, regardless perhaps of whether ischemia has been demonstrated, although it's sometimes easier to convince a patient to undergo repair when they feel well if you've been able to demonstrate ischemia. These lesions also come with thrombotic complications. It's uncommon, but this is a case from the literature of an unrepaired ALCAPA, and you can see on the angiogram image that not only is there sluggish flow in the right coronary artery, but on a later frame you can see there's actually a filling defect, and this was a thrombus which had formed in the right coronary, which led to an acute infarction presentation. And then this is a patient of mine who underwent ALCAPA repair, and I routinely follow these patients with CT afterwards to look at the quality of the repair and make sure everything looks fine. This guy actually didn't have really any symptoms, as I recall. This is 1 year post-repair. Here's the aortic root. You can see the proximal portion of the right coronary is filled with contrast, but distally you can see that the attenuation value in the right coronary is significantly lower. And if we look at that in other views, what you can appreciate is that the entire dilated right coronary system is full of thrombus. So in view of this, I've now moved to a strategy of anticoagulating post-operative ALCAPAs and ARCAPAs for 1 or 2 years. There's absolutely no data to support that. I'll be interested to hear what the rest of you do, but I'm concerned that in my experience, we do not see any significant coronary remodeling after surgery. These coronaries remain significantly enlarged, but now with a much lower volume of flow than they had previously. So having seen this once or twice now, I tend to anticoagulate at least for a couple of years, and then sometimes put people on aspirin and clopidogrel afterwards. And as I say, there's absolutely no data to support that. That's just a personal point of view. So this next category contains most of the work for ACHD cardiologists and congenital surgeons. And in the interest of time, I've included just one slide on coronary fistula. So, as you know, a fistula is a connection between a coronary artery and either a cardiac chamber or a great vessel. And the right atrium, right ventricle, and the coronary sinus are the commonest sites of drainage, as is the pulmonary artery. So small fistulae, such as those from the LAD to the PA, they're common, they're relatively common. They don't need anything doing about them at all. Volume loading is the most common concern with medium and large fistulae, and one of the commonest causes is the circumflex coronary artery fistula, and you can imagine this causes quite significant volume loading. And then on the right is a patient of mine who has a circumflex to CS fistula, shown here, and she was laid up in bed for a week following an orthopedic procedure. She was usually a very physically active patient, a lot of gym, climbing mountains, all sorts of very physically active things. But she was laid up in bed for a week following this orthopedic procedure, and perhaps because of reduced exertional flows, she ended up thrombosing her fistula. And so sadly, when she presented to the emergency room with typical chest pain, she was essentially ignored because she was female and 28. And for some reason, even SCAD wasn't considered. And this woman is intelligent and articulate, but still got missed in the emergency room, and unfortunately suffered luckily a limited circumflex myocardial infarction as a result. Happy to say she's doing well and has gone through 2 pregnancies with no trouble since that time. So anyway, the indications to close a fistula, they include obviously large high flow shunts, particularly with chamber dilatation, ischemia, LV dysfunction, and of course heart failure. Simple lesions can be embolized, but more complex lesions and things like this, for example, usually require surgery, especially if they're aneurysmal, or if there exist multiple terminations of the fistula, or if there are other lesions that need simultaneous surgical correction. Now, moving on to the anomalous coronary artery from the opposite sinus, particularly the right coronary artery. This is probably the most important lesion of the talk. These are not as rare as you might think. I'm sure you've all seen multiple examples of this, and they generate the most debate in my experience. So last year, for example, I've already seen 5 patients with anomalous RCA from the left sinus. And the main cause for concern is the sudden cardiac death rate. So, you know, the very first case I showed you was of an anomalous left coronary, and that has a quoted mortality rate of about 60%. Now, luckily for the right, the anomalous coronary artery from the right, this is a reduced mortality, but quoted levels are still in sort of the 25% range. So certainly enough to be of concern. CT, unfortunately, has created a mini epidemic of these because they're often incidentally found and sometimes found later in life. And then the question is always, well, what on earth do you do with them? So I want to take a moment, and I hope this isn't patronizing to those of you who know this already, but I want to take a moment to emphasize the difference between an intra-arterial vessel and an intramural one, because I think it's an important distinction. An intra-arterial vessel is one that simply passes between the aorta and the main pulmonary artery in a so-called malignant course. Now, these may or may not be malignant, but in 15 years, I've yet to see anyone with this kind of coronary alone have any major issue, let alone sudden death. However, when we talk about ALCAPA, the anomalous right coronary from the opposite sinus, we're usually talking about a right coronary which passes through the actual wall of the aorta in the first few millimeters of its course. So here's a pathological specimen here. This is the aorta. This is the right coronary origin, and you can see it's actually running in the wall of the aorta and becomes relatively slit-like an oval shape. This is a classic appearance as it passes through the wall in the first few millimeters. And many of us believe that this is indeed a risk factor for sudden death. So the problem is that the majority of patients with this lesion don't all have symptoms. They don't die, most don't die. And particularly after reaching middle age, almost nobody dies. So should we repair them all to save a few, or should we try and be more selective? This is a classic number needed to treat problem, and we don't know exactly what that number would be. So let's have a talk about how I approach it. Before we do, why do a few die but most don't? Well, we don't know the answer to that for sure. So the guy with the most experience, I think, with this lesion is Paolo Angelini from the Texas Heart Institute, who's published numerous articles and even a book on this subject. And he's been very interested in using IVUS to look at the ostial lumen. And they've certainly demonstrated, as you perhaps might expect, that there's lateral compression of the ostial lumen during systole. So they looked at this using IVUS and dobutamine atropine challenge. Interestingly, though, they also showed a degree of compression in diastole, which was quite variable from patient to patient, and perhaps explains the inconsistent natural history from patient to patient. And it may be that the thickening and the stiffening of the aortic wall that occurs with aging, perhaps that accounts for the relatively benign behavior of this lesion in some of the older patients. Now, luckily, I don't think we need IVUS or pathology in order to tell us whether a coronary artery has a proximal intramural course or not, because these days the spatial resolution of CT is more than adequate. So when you see a coronary artery that tapers rapidly, like this one does, then it is always intramural at surgery. This is a classic appearance of an intramural coronary artery. I've never seen a case where it looks like this and is not intramural. And here on the top right, again, we're demonstrating the slit-like appearance of the ostium as it passes through the aortic wall. Now, I I used to do stress MR on all of these patients. I've vasodilator stress MR, and I've included this case because it's one of the few cases I have with a convincing perfusion defect in the right coronary territory that has disappeared at rest. Generally, I would say that I have not seen a lot of ischemia with vasodilator stress MR. It may be that it's the wrong test, and you'll see in a moment that I generally prefer other tests for this lesion nowadays. One approach that has been taken is to use exercise PET. This is obviously not available in every center, but at this particular center, they used exercise with ammonia PET in patients with anomalous right coronary arteries. And they had some interesting results. So here are a couple of images from their paper. These are two different patients. In each case, there is a slit-like intramural right coronary artery. I would say that both of these look pretty severe. In fact, they always look severe. Every intramural right coronary artery looks severe when you look at it in cross-section. But they demonstrated differential flow results, really, between some of their patients. So, for example, this is a patient who had no ischemia. I'll just take a moment to explain what we're looking at here. These are bullseye plots. It's simply a way of displaying 17 segments of the LV myocardium in a single image. So you have 3 rings, an outer ring that represents the basal layer at the base of the heart. The middle ring represents the mid-ventricular level, and the inner ring represents the distal ventricle and the apex. So at stress here, we see a gray that is very similar to the gray that we see at rest. Unfortunately, reading gray is difficult. It's usually easier when it's color, but take it from me that there's no major difference in appearance between stress and rest in the inferior wall in this patient, and this was called negative, which I think is right. And then compare that to this patient here, where there is a reduction in the intensity of signal in the inferior wall. The counts are reduced in the inferior wall at stress compared to rest, and here's an ischemia map suggesting that there is significant ischemia in this patient. So we have 2 patients with the same lesion. One seems to have ischemia and the other one doesn't. And in fact, that was very much the message of the paper, really. They had 27 adults in all. 14 patients had no ischemia with exercise ammonia. 13 patients did. So it's a little bit like flipping a coin, whether your patient has ischemia or not. Here's an example that went to surgery with the artery prior to unroofing here, and you can see what looks like a significant ischemia defect with a reversible map showing severe ischemia. From the looks of it, severe ischemia. So perhaps all sorted. So all we need then maybe is exercise ammonia. Well, maybe yes, maybe no. I think it's a bit more complicated than that. So here are 3 different patients. This is now patients that we've done here in Ottawa. These are 3 different patients, each with an anomalous right coronary artery. In each case, it's slit like an intramural at the ostium. Each of these looks pretty severe to me. And we took a different approach. Rather than using exercise ammonia, we in fact used dobutamine stress rubidium. And the reason for that is that when you use rubidium, with dobutamine, you're able to get not only relative perfusion images, but you are also able to get quantitative flow down each of the arteries in mils per minute per gram of tissue. So we felt that might be more useful than simply having a relative perfusion pattern. Let me explain what I mean. These 3 patients each had stress rubidium, and here's the flow map in patient A, where there appears to be absolutely equal flow in all zones, in all coronary territories. Patient B has something of a perfusion defect in the inferior wall. Patient C has a more obvious defect in the inferior wall. So here, if we'd done this by ammonia, where we only had these maps, we would say, well, patient A has no ischemia. Patient B maybe has mild ischemia. And patient C looks as though they have more significant ischemia. So the same lesion behaves differently as we go from patient to patient, even though to me, the anatomy looks really very comparable and looks severe in each case. But it gets even more complicated than that, because when we look at this patient, or these 2 patients with what looks like ischemia, and we look at the absolute flow values for the right coronary, we see that although the flow for the right coronary is lower than the flow for the left system, the absolute value is still normal. And this is the problem with relative perfusion imaging. If you have a patient who has normal flow in all three territories, but the flow in the left system happens to be higher than the flow in the right system, you will get an apparent defect. You get a defect because this is a relative flow map. And so we're still in a little bit of a difficult situation here because we have what is a difference in flow, and this probably is genuine due to stenosis. This is probably genuine due to the stenosis of the right coronary artery, but the absolute flow in this coronary is still normal. So we can say with certainty there's a difference in flow, but it's still difficult to say with certainty that there's actually ischemia. And so I think really the jury is still out on how helpful stress imaging is. I think most of us will tend to operate on a patient with flow of this sort, particularly if they have symptoms, but whether we should be strictly calling it ischemia is hard to know. Now, of course, you might argue that this is an artificial challenge with dobutamine, and if we were able to measure flow with true exercise, we might find that this number drops even further below the normal threshold, and therefore there would be genuine ischemia, and I think that's quite possible. Okay, so moving on, we're told that you can never say never in medicine, but I want to quickly show you 3 lesions that I think you almost never have to worry about. The first 2 come from a journal courtesy of our friends at Great Ormond Street. So on the left, you see a retroaortic circumflex. This is a very common lesion. It passes behind the aortic root and then reaches the left AV groove in the normal way. In my opinion, this never causes ischemia. I have seen 1 or 2 occasional case reports suggesting that it does, but in 15 years and lots of stress testing, I've never been able to prove any ischemia with these lesions. I think most people think this is benign. This is an anomalous left system coming from the right, but with a benign course passing in front of the main pulmonary artery. It's not intramural, there's no slit-like origin. Really, the main importance of this is if there's going to be surgery on the right ventricle, perhaps a tetralogy patient, where there's going to be surgery on the outflow tract. This needs to be identified in advance, as transection of this during surgery inadvertently would lead to a large infarction of the left ventricle. And then this third lesion, the transeptal left main, I just want to spend a couple of minutes on this. It's usually incorrectly described as having a malignant course. In fact, this is not slit-like. It takes a deep dive into the septal myocardium before emerging further down the ventricle in the interventricular groove. It doesn't have osteal narrowing, it doesn't have intramural passage. And I would say that 99 times out of 100, this does not cause ischemia or sudden death, and it should be left well alone. But there's always concern about this. Here's an example. This is a patient who I saw at the end of last year, young competitive tennis player with a transeptal left main. You can see it here. And he did a bike stress echo. He went on for 17 minutes. He achieved 10 METs. He reached his target workload. We couldn't get his heart rate any higher because he was so fit, and he had no symptoms at all. And maybe that's reassuring enough. But the problem was that he was going to the States on a tennis scholarship, was going to be playing at the very highest level. And we felt we just had to try a little bit harder to reassure ourselves as well as him that should be reasonable. So he went on and had dobutamine stress PET, and you can see he's got a completely normal flow here in all areas. It's got phenomenal stress flow. Normal stress flow in our lab is 1.5. In other labs, it's 1.7. But you can see he's getting flows of 5 liters per minute per gram of myocardium. And flow reserve, which is simply stress flow divided by rest flow, should be above 2. Well, he's got a flow reserve of over 8. And even in the left system, the flow reserve is 9. So, I think we can be reassured that this guy can go on and play tennis for the rest of his life without any risk whatsoever. We didn't always have access to PET. I was working in Toronto. We don't have flow PET in Toronto, and so occasionally we had to get creative. This was a case that Michelle Keir wrote up when she was a fellow in Toronto, and this was another transeptal left main in a patient who was having episodes of ventricular tachycardia. This is his CT scan at rest. You can see that again, it looks like the last patient. There's a long segment that passes through the septum, but it's not slit-like, it's not intramural, and in theory this ought to be completely benign. We went on and did a vasodilator stress MR. There was no perfusion defect. He was presented at conference, and there was ongoing concern because of his VT that this was in some way ischemically driven. And so we wondered what to do next. And then we came up with the idea of trying to do dobutamine stress CT. So we gave him dobutamine, and at 20 mics per kilogram, he went into monomorphic VT. At 130 beats per minute, he was well, he had good blood pressure. And since it only takes about 10 seconds to acquire, or less, in fact, to acquire the CT images, we quickly acquired them and then turned off the dobutamine. So this is a CT, a short axis reconstruction acquired in VT at 20 mics per kilo per minute of dobutamine. And you can see there's completely normal wall motion in the LAD territory. There was also no evidence of compression of the coronary. I'm not showing that here, but the LAD did not appear to be significantly compressed. So this is probably not an ischemia-driven VT, and in fact, the EP team subsequently confirmed that he had fascicular VT, and he went on and had a successful ablation. Now, having told you for the last 2 minutes that a transeptal left main does not cause ischemia, I feel duty bound to show you the one case in the literature that suggests that occasionally it can be. And again, this is an exercise ammonia PET in a man with a transeptal left main. And this is an interesting case. He had a vasodilator SPECT first. This is rest and this is stress. It looks completely normal. Vasodilator SPECT completely normal. Exercise ammonia, we get a dropout in the left coronary territory. And I'm not sure why this transeptal left main is not playing by the usual rules. It may be ischemia, maybe the exercise genuinely has brought out ischemia, maybe it's a relative perfusion defect. Again, remember from the rubidium data I showed you that you can have significant apparent differences in perfusion, but all perfusion being above the normal threshold. So maybe it's ischemia, maybe it's not, maybe there's some slight narrowing here, I can't tell, and this is windowed such that I'm unable to tell whether there's relative narrowing at the ostium. But this patient did have chest pain during exercise, and he did have transient ischemic dilatation. So I suspect that ischemia was present, and his symptoms abated completely after surgery. So although this is the only case I have ever seen in the literature or personally where ischemia was demonstrated, because of this one case, I continue to test all of my transeptal left mains, even though I've yet to find one that is positive. Okay, let's talk a little bit about testing. We've kind of done that as we've gone along, but these are the things that I think testing should try and answer. It's not simply the anatomic course of the vessel, but as you've seen, it's the effects of the anomaly on the relevant cardiac chamber and also upon perfusion. And then, as you've also seen, when the vessel is aneurysmal, it's important to establish whether or not it contains thrombus, since this carries a risk of distal embolism. There are some additional questions that are important to try and answer, depending on whether the imaging is for an unrepaired lesion or a previously repaired lesion. Restenosis at the reimplantation site is probably the most important question following repair. Obviously, we're very interested in whether there's been normalization of perfusion. And for the ALCAPA or ARCAPAs, I'm interested in whether the coronaries are still enlarged, but the answer seems to be yes, they are. This is enough to make your heart sink, and I won't go through it in any detail. The point of showing this slide is to really suggest that you've got to choose your test according to the question in mind. But since they all have strengths and weaknesses, you usually end up doing more than one test. And I do at least two, and sometimes I've been known to do more if I'm struggling with making a decision about the patient. So what do you need to do? You need to keep calm and be aggressive. There is absolutely no role for being half-hearted with coronary anomalies, in my view. Particularly with things like the anomalous right from the opposite sinus. I think as an institution, you either take a decision that you're simply going to repair all of them, and there are some US institutions that will do that, or you take the approach that you will try and be more selective based on testing, and in that case, I think you have to be very aggressive with testing. You want to have a high degree of confidence if you decide not to operate that you think the patient has a very low risk of sudden death. So I'm very aggressive, as I say, and these are the things I'm thinking about when I'm trying to choose what to do. First of all, I think everybody needs a cardiac CT. I think you need to establish the anatomy. And as I've said, I think a CT is good enough for establishing whether there's an intramural component or not. And then I'm usually left trying to decide between one of these options. So when I'm looking for ischemia, I like to have at least one test which uses exercise. That's often when patients get their symptoms. But since wall motion abnormalities appear later in the ischemic cascade, I also like to have a perfusion test as well. Now I found, as you've seen, that vasodilator stress MR is perfectly adequate for ALCAPA and ARCAPA, but is often unrewarding for the anomalous right coronary from the opposite sinus. And there, as you've seen, I preferred dobutamine PET. That's a luxury that most centers don't have, and a good alternative might be, for example, stress MR, but using dobutamine as the stress agent. The problem there is that many radiology departments don't feel comfortable administering dobutamine, so you have to come to some kind of arrangement to be there to supervise. There isn't a lot of published experience using FFR in coronary anomalies. It's unclear whether or not it's helpful with intramural vessels. IVUS I don't find helpful at all. It does clearly demonstrate intramural segments and slit-like ostia. I think those things are just as clearly seen by cardiac CT. So unless you plan to study dynamic change in ostial cross-sectional area by giving dobutamine during IVUS, then I'm not convinced that there's much point with that technique. And so there are a number of considerations when considering whether or not to intervene upon an anomaly, as well as what form intervention should take. Thank you very much. I believe that all the ALCAPAs and ARCAPAs should be repaired, regardless of symptoms or ischemia, unless perhaps they present an extreme old age. So I do have one 87-year-old unrepaired ARCAPA who's doing perfectly well, for example. Moderate or large coronary fistulae need to be addressed either surgically or by catheter. And in my experience, as I've said, the anomalous right coronary from the opposite sinus is usually the most challenging decision, especially if it's asymptomatic and ischemia can't be absolutely proven. I think part of the decision making is based on the age and also what level of exercise the patient wants to undergo. I think it matters when you're looking at right coronary lesions, whether it's a dominant right coronary or not. And we've talked about the importance of intramural status. So there is, I think, a sort of hierarchy of seriousness, if you like, and these things always come to congenital surgical conference, and they range from not very much argument to really quite a lot of argument, depending on what we're talking about. As we move outwards, the indications get a little fuzzier, and the probability of multiple people disagreeing with each other at conference rises. And we have to steer, of course, I think, as the patient's advocate between the interventionalists who want to do everything by catheter and the surgeons who refuse to accept that anything is ever as good as an operation. So that's been a whistle-stop tour of coronary anomalies. I hope it's been helpful. I look forward to the discussion. I have 2 or 3 additional unicorn cases that I can show if there's time, but I think for now I'll stop and let people ask questions.
Thank you very much, Andrew, for this excellent overview about a very difficult topic, the coronary anomalies, diagnostic aspects, and also therapeutic aspects, how should we treat these patients. I think just to repair every coronary anomaly, that's an overshooting problem. There's some questions in the chat. Dr. Coleman has a question regarding ALCAPA. First of all, so thank you for the excellent review. He said, positive ALCAPA, the dilated right cornea does not come down to normal levels. That's capable of both patients. And you say...
Sorry, I was breaking up a bit there, Owen. Let me just see if I can see the chat. And then
just open the chat.
Yeah, sorry, I've just got to find it. It's not on my window here.
It's just on the top. Go right. No.
Yeah. Okay. Yeah. Okay, I've got it, Owen. I'll just read it. Yes. He said anticoagulate for a year or 2. Yeah. Okay. So Jack says, okay, you're not being completely logical, Andrew. You said anticoagulate for a year or 2, but on what basis would you stop? And is there actually an argument to be made for indefinite anticoagulation? Yeah, that's a really tough question, Jack. As you know, we didn't used to anticoagulate anyone for this at all, and there are only a handful of really a handful of reports of thrombosis. So that's what I was trying to indicate. I try and steer a middle course. When I was in Toronto, Ed Hickey and I talked about this, and we decided that as a minimum, we would anticoagulate properly with warfarin for 1 year. And then after that, we would have a discussion with the patient. And my feeling has been that most of the patients have chosen to either transfer to a NOAC, or if they were unkeen on that, have been left on aspirin and clopidogrel. I don't think we can know the answer. My preference is to have them on something indefinitely, and I'm not sure that aspirin is quite enough by itself, but I don't think we know.
I fully agree with that, Andrew. I just want to emphasize the endothelium is completely abnormal. These coronary arteries are dilated.
I see a question about thrombosis in patients with dilated coronary artery or coronary fistula. Do you recommend anticoagulation during pregnancy? Well, it doesn't often come up, but if it's an I suppose it depends when you find out about the lesion. So if it's an ALCAPA or an ARCAPA, hopefully it's been fixed prior to pregnancy. If it hasn't been fixed prior to pregnancy, I actually, I might worry about ischemia or heart failure or something else, but I don't worry about thrombosis because of the high cardiac output in pregnancy. So paradoxically, the ones that are unrepaired, I worry less about in pregnancy from a thrombosis point of view. If it has been repaired, then I've never been in that situation, but it's a good question. I think I probably would recommend treating and anticoagulating a bit like we would for a mechanical valve in pregnancy. Now you could argue, well, maybe you don't need to because, again, you've got a higher cardiac output in pregnancy, but it's still probably going to be less than it was before. So it's a very good question. I've never faced it. I think I would be tempted to in a repaired ALCAPA or ARCAPA because the coronaries remain huge. They just don't remodel. Another question about anticoagulation, Coumadin or NOACs. So as I was saying, for the ALCAPAs or for a coronary sinus fistula that thromboses, I've tended to start for a year with warfarin. There's no data whatsoever, and then after that, go on to a NOAC, or as I say, down the line, maybe 3 or 4 years out, perhaps go to aspirin and clopidogrel. What about? So Erwin has a question. What about stress tests? Isn't a physiological stress test exercise superior to a pharmacological stress test? I think generally yes. I agree with that, and maybe wasn't entirely clear, but every single one of my patients gets, at the very least, treadmill stress echo. So everybody does a bike stress echo or a treadmill stress echo, regardless. And then these perfusion tests that we do, those are always on top of that. Now, I think the interesting question, based on that data that I showed you, is whether we should be doing exercise ammonia or whether we should be doing dobutamine rubidium. Because with ammonia, you get the exercise and then you get relative perfusion, but you don't get any quantitative flow data. Whereas with rubidium, you get quantitative flow data, but you can't do it with exercise. And you might say, well, it's just another tracer. Why can't we do exercise rubidium? Well, it's got a very short half-life. It has to be infused continuously. That's one reason. The other thing is that when we collect quantitative flow data, it's real time. So we're collecting it over the first 2 minutes following the infusion of rubidium. So if the patient is exercising, there's simply too much diaphragmatic motion to allow each of these individual frames, these perfusion frames, to be acquired and then to be superimposed. There's just simply too much motion. The motion correction algorithms aren't good enough at the moment. Maybe they will be in the future with AI, but they're not good enough at the moment. And so we have to have patients static if we want quantitative flow. So that's a long answer to your question, Owen, but I do agree that everybody should have some kind of exercise stress, regardless of what else you do. Okay, question. Actually a comment from Kate. Hello, Kate. Kate English in Leeds says, That's interesting. So Kate says she would anticoagulate in pregnancy in repaired ARCAPA or ALCAPA with residually dilated coronaries. The flow remains sluggish. Yeah, I agree. And she would use low molecular weight heparin for that. She says she probably wouldn't be as aggressive as with a mechanical valve. So that's interesting. Thanks very much, Kate, for that. And then we have a question. Does age change your management of symptomatic patients, of asymptomatic patients with anomalous coronary artery from the left sinus and intraarterial course with high-risk features? Well, if it's an anomalous right coronary from the sinus, it will have high-risk features. Almost invariably, we're talking about patients with a slit-like origin. And the only way in which it changes my approach is that if I have 2 or 3 negative ischemia tests, I feel even more relaxed. But I still test people regardless of age. People in 50s and 60s still get tested. Very few of those people actually have any abnormalities on testing. And in 10 years or more of doing this, those patients in whom we've made a decision not to operate, nobody has died yet, touch wood. So age is important, but I don't think it's the major determinant. So that's it with questions from the chat. Are there any direct questions that anybody has? Or would you like to see a couple of unicorns just to finish up?
Andrew, I have a question regarding age.
Yeah.
Does the age 35 younger or older play a role when we consider I noted the chat.
I'm sorry, Owen, it's so choppy I can't understand. Your audio's choppy.
Yeah, I wrote a note in the chat.
Oh, you wrote a note in the chat. Oh, okay. Age less than or greater than 35 years is also considered during the decision process to proceed. Do you agree? Yeah, I mean, I think age is important. But if you've got a 50-year-old with symptoms and you think you've got a positive ischemia test, I think you've got a reason to operate. So I think you can perhaps risk stratify in terms of sudden cardiac death a bit with age, but I think it's just one more thing to think about. I do worry more about the younger ones. They just tend to be more physically active, of course, and we think that this is an exercise-induced arrhythmia, causes sudden death. So yes, I worry about age, but I don't think age is the primary stratifier. Oh, Owen wants at least one unicorn before we conclude. I've got 3 with 1 slide for each, so they're pretty quick. So let me see what I can find. Okay. So, do you believe in unicorns? Yes, they exist. So, unicorn is just a very uncommon thing, in my opinion. Here's a unicorn. Unicorn 1, 37-year-old lady with Noonan syndrome who was having palpitations. I honestly don't remember why we did the MRI. I think it was because the echo was very abnormal. As I recall, there were multiple serpiginous structures along the left heart border that appeared to have flow, and nobody was quite sure what was going on. And this is one of the more unusual things I've seen. These are axial images. This is the aorta. This is the left main coronary, which is about 1.5 centimeters in diameter. This is the right coronary, which is massively dilated with thrombus. Here's a long axis view of the right coronary. This is 2 centimeters in diameter, this right coronary, and it's full of thrombus. It's not occluded, there's still a passage through, but there's lots of thrombus in it. And when you look at the late gadolinium enhancement imaging, there's infarction in the territory of the right coronary. And in fact, there must have been thrombus in the LAD because there's infarction in the anterior wall as well. So, you know, this is something I've never seen before in Noonan syndrome, coronary dilatation of this sort, no history of Kawasaki or anything else. And I thought, well, this is a one-off that nobody has ever seen before or since. The funny thing about unicorns is they're not as rare as you think they are. When I went to the literature to look, there were multiple reports of coronary artery ectasia in Noonan syndrome. Maybe some of you knew that already or have seen this, but it's not something I'd ever seen before. This is unicorn 2. This was a 48-year-old man who came to attention because he complained of chest pain every time he was swinging his axe digging up roads. And he was born with tetralogy with absent pulmonary valve. As you know, they get these enormous central pulmonary arteries. He had a positive exercise test with ST depression during exercise, a completely normal stress perfusion MRI, and went on for cath. And the alert angiographer noted that there seemed to be a smooth tapering at the ostium of the vessel, wondered if there could be some extrinsic compression. We tried to prove that using cardiac CT, and indeed you can see that in systole, the left main is being compressed by this enormous pulmonary artery, and he went for surgery and pulmonary artery plication and did very well afterwards. And then unicorn 3 is a unicorn wannabe. This is just an interesting one that popped up the other day. This is a CT where the right coronary artery is actually not sitting in the right AV groove where it should, but is actually sitting in the wall of the right ventricle. You see that a little better here. It's passing here. This is the cavity of the RV, and this is the muscle of the RV wall. So this is a transmural right coronary artery. You can see the bridging on the volume rendered image. And on stress rubidium PET, this was completely normal flow. I'm not showing the flows here, but quantitative flows were entirely normal as well. So look out for unicorns there. They do pop up every now and then. And I think that's all I have for you. Thank you very much.
Okay, so thank you very much, Andrew, for this excellent presentation. And we learned a lot during the last 1 hour. I wish everybody a great weekend, and see you soon.
Thanks very much, Owen. Thanks everybody for coming. Have a great weekend.